Good evening, my name is Raven Mosley. I'm a P3 student, and this evening I will be discussing the Amplify trial. And the title of the article is Apixaban Reduces Hospitalizations in Patients with Venous Thromboembolism, an analysis of the apixaban for initial management of pulmonary embolism and deep vein thrombosis as first-line therapy, or simply the Amplify trial. So to start off, the authors of this article are Shai-Chin Liu, Margot Johnson, Jack Mardikian, Hermant Patak, John Thompson, and Alexander Cohen. And to give you a little bit of background of the two therapies that are going to be discussed, the first therapy is apixaban, which is a factor Xa inhibitor, and it's marketed under the brand name Eliquis. It comes in the form of a tablet. There's two different dosages, the 2.5 and the 5 milligram tablet, and it has several indications. The first indication is for stroke risk reduction and non-valvular atrial fibrillation. Another indication is deep vein thrombosis and pulmonary embolism treatment and reduction in risk of recurrence of both of those. And third indication is prophylaxis of DVT after hip or knee replacement surgery. So to give you a little bit of background about the trial, it was sponsored by Pfizer and Bristol Myers Squibb. And to start off, venous thromboembolism is a major health concern, and it's the third leading cause of cardiovascular death. In the apixaban, or in the Amplify trial, apixaban was found to be non-inferior to enoxaparin and warfarin in preventing recurrent symptomatic VTE or VTE-related death, and it had an incidence of significantly less bleeding. This analysis evaluates the effects of apixaban versus enoxaparin and warfarin on all-cause hospitalizations during the Amplify trial. So the objective of the trial was to assess the efficacy of apixaban as compared to enoxaparin and warfarin in the reduction of all-cause hospitalizations in patients with VTE who were enrolled in the trial. So the trial design. The Amplify trial was a randomized, double-blinded, active control, parallel group, non-inferiority trial. And what that means is it was randomized, so each patient had an equal chance of receiving the desired therapy, which is the apixaban. It was double-blinded, so neither the researcher nor the patient knew which therapy the patient was receiving. And there was no specific location discussed in the article, but it did say that there were 358 centers with patients were enrolled in 358 centers in 28 different countries. So the protocol was approved by the Institutional Review Board and at each center, and written consent was obtained from each patient that participated in the trial. So the inclusion criteria, the patients who were included in the trial were patients over the age of 18, both male and female, and they had to have had confirmed DVT or deep vein thrombosis or pulmonary embolism, and they are provided written consent. Now, the exclusion criteria included patients who had active bleeding or had high risk of bleeding, for obvious reasons, patients who had less than 6 months of coagulation planned for the most recent DVT or pulmonary embolism, because the trial did last for 6 months. And then any patient who had contraindications to treatment with enoxaparin and warfarin. Any patient who had platelet and hemoglobin deficiency, so if their platelets were below 100,000 and if their hemoglobin was below 9, they were excluded from the trial. And then patients who had renal insufficiency, so if they had a serum creatinine of greater than 2.5 or a creatinine clearance of less than 25, they were excluded from the trial. And then patients with elevated liver enzymes, so elevated AST and ALT enzymes, they were excluded. So the subjects for the trial were individuals with deep vein thrombosis or symptomatic pulmonary embolism treated with anticoagulation therapy. And so the primary endpoints, the incidence of recurrent symptomatic VTE or VTE-related death and major bleeding events. And then the secondary endpoints were the time to the first hospitalization, hospitalization within 30 days of the index event. And what I mean by the index event is the patient had some type of exacerbation of VTE, and that sent them into the hospital. And then the length of hospital stay and the reasons for hospital admission were also secondary endpoints. So no follow-up was discussed in the in the article, and the duration of the article, the duration for the trial lasted 6 months. And then the population for the trial, there were 5,365 patients who participated in the trial. The intention to treat population included 2,691 patients who were assigned to receive apixaban, and then 2,704 patients were assigned to the enoxaparin warfarin treatment group. So there were 2 treatment arms. The first arm was the apixaban 10 milligrams twice daily for 7 days initially, followed by 5 milligrams twice a day for 23 weeks. Or the other treatment arm was the enoxaparin at 1 milligram per kilogram of body weight every 12 hours for the first 5 days, and followed by warfarin, or the bridge therapy for warfarin, and they were continued on that for 6 months. Analysis was a statistical analysis, so the analyses were conducted using the intention to treat population. A time to event analysis was conducted for the first hospitalization for each treatment group, and the curves for each analysis was calculated using a Kaplan-Meier method. A Cox proportional hazards regression model was used to examine the effects of treatment with apixaban and enoxaparin warfarin. In addition, a t-test was conducted with a Satterthwaite unequal variance adjustment, which was performed to examine the average length of stay for the hospitalized patients after the VTE or pulmonary embolism event between the 2 treatment groups. So baseline characteristics. The baseline characteristics were pretty similar among each treatment group. Most patients had normal renal function, and their weights fell between 60 and 100 kilograms. And then most patients were less than 65 years of age, although there were a few patients that, weighed more than 100 kilos, and there were a few patients that were over the age of 65, so they fell into that elderly range. So for the results, the primary endpoints were met. The results showed that the rate of major bleeding events was significantly reduced with apixaban as compared to enoxaparin and warfarin. So for apixaban, the reduction was a 0.6% reduction versus warfarin, which was a 1.8% reduction. And in the case of the recurrent VTE, apixaban was also found to be inferior to enoxaparin and warfarin. That's a 2.3% versus 2.7%, with a 95% confidence interval of 0.6 to 1.18, and a p-value of less than 0.001. So with that p-value being very, very low, that is a statistically significant event. The secondary endpoints were also met for the hospitalized patients. Over the course of the 6-month period, it was found that the apixaban group had 182 all-cause hospitalizations, which was less than the enoxaparin and warfarin group, which had 218 hospitalizations. And of those 182 patients, only 5.7% of the apixaban patients had a recurrent hospitalization, as compared to 7% in the enoxaparin and warfarin group. So that also had a very, very low p-value, making it a statistically significant event. And then the mean length of stay for the hospitalized patient was shorter in the apixaban treatment group, with the average being 10.2 days for the apixaban treatment group and then 11.7 days for the warfarin treatment group. And the reasons for the hospitalizations were pretty much the same for each group. The reasons for the hospitalizations were VTE recurrence, bleeding events, and cardiovascular events, all of which were reduced in the apixaban treatment group. And then for the adverse effects, with warfarin comes a lot of adverse events. It's very inconvenient for the patient because they have to take frequent INRs and blood tests. So because there's really a lot of dietary and drug restrictions with warfarin, so that leads to a lot of dose adjustments. And you don't really see that with apixaban. There's really no food or drug interactions other than major bleeding events. That's really the only adverse event the article described. And then for the author's conclusion, The trial successfully demonstrated that apixaban reduced all-cause hospitalizations, it reduced the number of hospitalized patients, and reduced the average length of stay for patients treated for exacerbations of VTE. In addition, the reduction in all-cause hospitalization was observed within the first 30 days after the index event, and that was mainly due to reduction in recurrent VTE and bleeding events in the apixaban treatment group. So it can also be assumed that with the reduction in hospitalizations and hospitalization length of stay, that could lead to tremendous cost reductions in future VTE treatment. So overall, the strengths of the article. So overall, the trial was conducted in a thorough manner. It was very thorough. The treatment parameters were realistic and appropriate for the trial. There were a large amount of participants, and because it was randomized and double-blinded, that significantly reduced the risk for bias. And it was sponsored by two very well-known pharmaceutical companies, so it's safe to say that the results are pretty reliable. Some of the weaknesses that I did find with the article is that although the population for the trial was appropriate, it didn't really include patients who had it didn't really say or comment on patients who may have had comorbid conditions, so like diabetes, thyroid issues, cancer, low body weight, and how those issues may have affected their treatment. And it also didn't report on any adverse effects of apixaban. It focused mainly on the disadvantages of warfarin, but it never really talked about any adverse effects associated with apixaban. And so just to summarize the article, the Amplified trial was conducted to evaluate the efficacy of apixaban therapy in the reduction of all-cause hospitalizations and major bleeding events in comparison to enoxaparin warfarin therapy in patients with venous thromboembolism. It was a randomized, double-blind, active control group study that utilized Cox proportional hazards regression models to interpret the results. The measures that were evaluated were incidence of all-cause hospitalization rates within the first 30 days of the index event, mean hospital length of stay, and rate of bleeding events. So to kind of put this into a pharmacy perspective, I thought the study was very well done and it produced excellent results. As a pharmacist, I would definitely use this study when evaluating patients for the patient's options for anticoagulation therapy. Seeing as how the study did prove that apixaban may be a better choice because it achieves the same desired results without having to inconvenience the patient. So there wasn't really any dietary restrictions. The patient doesn't have to go back and forth to the doctor for numerous blood tests. And there's always an increased risk for bleeding events with anticoagulants, but it's not as significant in apixaban as it is in warfarin. And also, with all the responsibilities that come with warfarin, I do think apixaban would be a better choice because it would definitely help with patient compliance, and it may also be a more cost-effective alternative to warfarin for the patient. And with that being said, that's all I have for you. Thanks.